grand rounds this morning. Today we have Dr. Sarah Kizilbash. She's a pediatric nephrologist here at the University of Minnesota, so hopefully most of you know her. She did her pediatric residency at Michigan, in Detroit, at Children's Hospital of Michigan, and did her pediatric nephrology residency here at the University of Minnesota. So please welcome Dr. Kizilbash.
Thank you very much for that introduction, and thank you for setting the expectations high. Well, I certainly hope it turns out to be decent, at least. And again, thank you for the opportunity to present my research here. The title of my talk today is Kidney Transplant Outcomes Associated with the Use of Increased Risk Donors in Children. So today I will review the epidemiology of end-stage renal disease in children in the United States. I will discuss the magnitude of organ shortage that confronts the transplant community. I will discuss the definition as well as the prevalence of increased risk donors. And I will also discuss the effect of increased risk donors on patient and graft survival after transplant. Fortunately, chronic kidney disease is not very common in children. Having said that, children with chronic kidney disease are 30 times as likely to die as children who do not have chronic kidney disease. So even though it's not very common and the numbers are small, the impact is huge and the consequences are dire. The incidence of end-stage renal disease in children varies by region. The incidence is highest in New Zealand, where it's about 18 per 1 million age-related children. This is followed by the United Kingdom and then the United States. In the United States, the incidence is about 16 per 1 million age-related children. So that means, in terms of absolute numbers, in the year 2015, there were about 1,400 new cases of end-stage renal disease that were diagnosed in the United States. The prevalence of ESRD is much higher than the incidence, and that has to do with the fact that the mortality of children with end-stage renal disease has improved over the years. The prevalence is highest in Finland. Sorry, I think the mouse is, it is. So the prevalence is highest in Finland, as you can see here, where it's about 100 cases per 1 million age-related children. And that is followed by the United States. Now, if you go to the previous slide, here you may see that the incidence in Finland is actually one of the lowest. And it's only 4 to 5 per 1 million children. So what that tells us is that people in Finland are doing an excellent job of keeping their children with ESRD alive. Finland is followed by the United States, where it's about 80 per 1 million children. So once the child reaches end-stage renal disease, some sort of renal replacement therapy is needed to keep them alive. This slide compares mortality between children with between children on dialysis and children with a kidney transplant. And as you can see, so this study was performed by Dr. Chavers, and we can see that even though the mortality has improved for dialysis patients over the years, there remains a significant gap between dialysis patients and transplant recipients in terms of survival. So on average, children on dialysis are about 6 times as likely to die as children with a functioning graft. Now, this slide tells us that there is a very compelling reason to go with kidney transplant for every child with end-stage renal disease. This slide compares growth outcomes between children. So not only is there a difference in mortality, but growth outcomes also differ between transplant patients and dialysis recipients. So this figure here compares height Z-scores for transplant patients and dialysis patients. So the dotted line is transplant and the solid line is dialysis. And you can see that transplant patients clearly do much better than the dialysis patients in terms of growth. So the final adult height is expected to be much better than that of patients on dialysis. This figure here compares growth velocity between dialysis patients, transplant recipients, and right up here, the general US population. Now, it is very, very pleasing and encouraging to see that transplant recipients, they do nearly as well as the general US population in terms of their growth velocity in the prepubertal years. But if you look at the dialysis patients, they significantly fall behind. Again, making the case for transplant for every child. And you can see that the p-value is less than 0.01. So again, these results are pretty significant. This slide tells us about neurocognitive deficits that we see in children with end-stage renal disease. This slide here gives the mean IQ scores per the age at the onset of ESRD. As you can appreciate, younger the age at the onset of ESRD, lower the mean IQ score. And this association between the age at ESRD and the IQ score is pretty linear. In other words, longer the duration of ESRD exposure, worse the outcome. So this looks pretty bleak. So is there anything that we can do to improve the outcome of children in terms of their development? Now this figure here compares achievement scores between transplant recipients, these bars here with lines, and dialysis patients, these solid bars. And they compared it both by age and by grade. And as you can appreciate, transplant patients outperform dialysis patients by a huge margin, both by age as well as by grade. And again, the p-value is significant for both these comparisons at 0.02 and 0.028. So there is absolutely no doubt about the fact that kidney transplant is far more superior for a child with end-stage renal disease compared to dialysis, and that kidney transplant is the way to go. Every additional day that a child spends on dialysis comes at the expense of their growth and development, not to mention poor quality of life. So then why do we not transplant every child with end-stage renal disease? What keeps our dialysis units full? Well, the biggest barrier to kidney transplant, or any solid organ transplant for that matter, is organ shortage. So what is the extent of this organ shortage? This data is from SRTR Annual Data Report. SRTR is a national database which includes data on all solid organ transplants. This slide here shows that in the year 2017, December 31st, 2017, by this time for the year, nearly 700 pediatric kidney transplants had been performed. Of these, 500 transplants were from the deceased donor, and only 200 transplants were from the living donor. In other words, this is 70%. So 70% of transplants were from deceased and 30% from living. Now, this may vary from center to center. Some centers may have a higher number of living transplants, but this is what the national data tells us. So there are two important points that we can infer from this. Number one, the vast majority of pediatric candidates, they rely on the deceased donor pool to get a kidney. Number two, this might be a little hard to appreciate, but over the last few years, there's actually been a decline in living donation for pediatric candidates. Now, this is worrisome for two reasons. Number one, there is no doubt about the fact it's well established that living donor transplants have superior outcomes compared to deceased donor transplants. The other thing is a decline in living donation also means that there is increased burden on the deceased donor pool. And here you can see a little blip up here, which further makes your organ shortage worse. This slide here gives us the prevalence of pediatric candidates on the deceased donor pool. So you can see that over the years, the number of candidates on the deceased donor list has increased. This number reached its peak in 2015. So there were about 1,500 pediatric candidates on the list that year. 1,000 new candidates were added to the list, and only 500 deceased donor kidney transplants were performed that year. This is adult data, which, as one would expect, is a lot grimmer. So in adults, in 2017, there were 72,000 candidates who were on the list for a kidney. Of these, 60,000 candidates were actively waiting for a kidney. And guess how many deceased donor transplants were performed for adults that year? Any wild guesses? Sorry, how many? Okay. Well, we do better than that. So there were 14,014 deceased donor transplants that were performed in adults. So this illustrates the huge gap between organ supply and organ demand. Now, this is adult data, granted, but adult data is relevant to children because they both share the same deceased donor pool, and children are not immune to the organ shortage. So the general perception is that children do not have to wait very long for a kidney. Shortly after being listed, they get called for a kidney. Well, the reality is not exactly that. This slide shows that about 50% of children get a kidney within a year, but the remaining 50% do not. And 20% of children have to wait 2 to 4 years to get a deceased donor kidney. And 15% have to wait, actually 15 years, for a kidney. So think of a child who has to wait 4 years for a kidney and think of what it would do to their development and growth. This slide gives us 3-year outcomes of patients who were listed, of pediatric patients who were listed on the deceased donor list in 2014. So in 2017, 50% of them had received a deceased donor transplant. About 20% were removed from the list for a living donor transplant, and about 20% were still waiting for a kidney. Again, these are not small numbers. And unfortunately, about 2%, the red or the pink line here, died while waiting for a kidney. So what can we do to address this organ shortage? Well, the very first step would be to minimize organ wastage. Despite the severe organ shortage, about 20% of kidneys are discarded annually in the United States. So which are these discarded kidneys? So these kidneys come from 3 main categories. The first category is that of expanded criteria donors. Expanded criteria donors are older donors. They're either older than 60 or they're older than 50 with comorbidities such as high blood pressure, high baseline creatinine, or a history of stroke. These kidneys are not good quality kidneys and are not likely to last very long, and hence they're often discarded. The second category is donation after cardiac death. These kidneys have prolonged ischemia times. Again, they're at risk of acute tubular necrosis and also not likely to last very long, and these kidneys are also discarded. The third category is what I will be talking about today. The third category is CDC-defined increased risk donor category. These kidneys, as opposed to the first 2 categories, are not low-quality kidneys, and chances are that these kidneys will last a long time. So who are these increased risk donors? So increased risk donors are individuals who may transmit bloodborne viruses, which are HIV, hepatitis B, and hepatitis C, to recipients through transplantation, despite testing negative on ELISA or nucleic acid testing. And this happens due to their window period. Window period refers to the interval between virus acquisition and virus detection by our conventional tests. The duration of window period varies by the test that's used as well as the virus that is being tested for. So if you use ELISA, the window period for HIV is 7 to 20 days. So if you have an IV drug user who abuses an IV drug about a week prior to donation, potentially that donor can transmit HIV infection to the recipient through transplant. The window period for hepatitis B is 35 to 44 days, and the window period for hepatitis C is 40 to 70 days. Now I can see 70 days is disconcerting, no question about that. But if you use nucleic acid testing instead, the duration of window period is significantly reduced. So for HIV, the duration is reduced by 12 to 13 days. So some texts say that the window period is then only about 10 days, 9 to 10 days. For hepatitis B, it's reduced by 21 to 36 days. And for hepatitis C, it's reduced by 26 to 60 days. So it comes from 2.5 to 3 months down to about 7 days. So based on these figures, OPTN, which is Organ Procurement and Transplantation Network, they've mandated that nucleic acid testing be used for hepatitis C screening for all donors, and that nucleic acid testing be used for increased risk donors for HIV. So how do we identify these increased risk donors? So it was in 1994 that the CDC first came up with guidelines to identify these increased risk donors. The purpose was to identify individuals who were at risk of transmitting HIV infection. So the focus of these guidelines was to identify risk factors for HIV. These guidelines were updated in 2013. There were 2 changes made to the guideline. One, the exposure duration was changed. So in the 1994 guidelines, exposure anytime within the preceding 5 years would get somebody labeled as an increased risk donor. In 2013, the duration was decreased to 12 months. Number 2, in 2013 guidelines, risk factors for hepatitis B and hepatitis C were also incorporated. So if you look at these guidelines, increased risk donors are individuals with high risk sexual behaviors, individuals who are IV drug users, and again, the exposure has to be within the preceding 12 months. A child who's less than 18 months born to a mother who's at risk of or has HIV, Hep B, Hep C. A child breastfed by a mother within the preceding 12 months who's at risk of HIV or has HIV. People in correctional facilities for more than 72 hours within the preceding 12 months. People with a diagnosis of an STD within the preceding 12 months. People who are donors with hemodiluted blood, where you cannot reliably ascertain their HIV, Hep B, Hep C status. People on hemodialysis within the preceding 12 months. Now, obviously, this is not going to be relevant to pediatric recipients, but for other solid organ recipients. And also, if anyone's exposure history cannot be determined, that donor is labeled as increased risk donor. So 2 comments about these guidelines. Number 1, as you can see, these guidelines are pretty conservative, which, depending on the risk, may or may not be appropriate, and we'll come to that. The other thing is that CDC defines the exposure period as 12 months. And as we've seen, that even if you use ELISA, the window period is at the most 3 months. So this period of 12 months may be more conservative than what you'd like to see, especially given the severe organ shortage. So what is the magnitude of this risk? Because we have to know what the risk is before we can counsel our patients. So this study gives us the estimated number of undetected window period HIV infections per 10,000 increased risk donors. And you can see that the risk varies by the type of high-risk behavior. Sorry, this mouse is not the best. So the risk is the highest for IV drug users. So if there is an IV drug user donor and you use ELISA to detect HIV infection, you will miss 12 infections out of 10,000 donors, which is 0.1%. We're not talking about 5%. We're not talking about 10%. We're not talking about 50%. We're talking about 0.1%. And this is with ELISA. If you use nucleic acid testing, then the risk of missing an HIV infection is 4.9 per 10,000 donors, which is only 0.05%. So again, the magnitude of the risk has to be taken into account when deciding whether to accept or decline increased risk donors. This slide shows the same thing for hepatitis C. So again, the risk is the highest for IV drug users. So if you use ELISA, the risk is 300 per 10,000 donors, which is about 3%. Well, 3% may make us uncomfortable. But if you use nucleic acid testing, that risk decreases to 32 per 10,000, which is 0.3%. Again, the risk is less than 1%. And the window period for hepatitis C using that is only 7 days, not 12 months. So how much of a difference can we make in the deceased donor pool if we promote the use of increased risk donors? So it has been estimated that under the newer guidelines, 20% of all deceased donors are increased risk donors. In other words, 1/5 of the entire deceased donor pool is made of increased risk donors. And unfortunately, this number is only expected to increase because of the growing epidemic of IV drug use. And it's also unfortunate, or well, one can argue either way, these kidneys are discarded at 1.5 times the rate of standard criteria donors. So, would it be justified to promote the use of increased risk donors in kidney transplant recipients in order to expand the deceased donor pool? What is the benefit that comes with increased risk donor transplantation? There has to be a benefit for somebody to take the risk. Rates of increased risk donor transplants in children and the outcomes associated with increased risk renal transplantation were unknown prior to the study that we did. We used the Scientific Registry of Transplant Recipients for our study. Again, this registry is a national database that includes data on all solid organ transplants that have been performed in the country since 1987. It also includes data on all donors and all waitlisted candidates. Our hypothesis was twofold. One, we hypothesized then patient and graft survival would be superior in increased risk donors compared with standard non-increased risk donors. The rationale for this hypothesis was the fact that increased risk donors are usually younger donors who lack comorbidities. So other than this slight risk of virus transmission, these are good quality kidneys. Our second hypothesis was that transplantation with increased risk donors confers a survival benefit to patients who are on the deceased donor list. In other words, patient survival was higher in IRD recipients compared with those who remained on the deceased donor list, declined the IRD kidney, and chose to wait for a non-IRD kidney. We identified all pediatric deceased donor transplants that were performed in the United States between January 1st, 2005 and December 31st, 2015. We used 2005 as our study start point because it was only in 2004 that SRTR started collecting data on the increased risk donor status. So during the study period, we found 328 IRD kidney transplant recipients. So our cohort included 328 IRD recipients and 4,850 non-IRD recipients. We compared patient and graft survival between IRD and non-IRD patients using the Cox proportional hazard model. And we evaluated the survival benefit of IRD transplant compared with remaining on the waiting list by using the sequential Cox analysis. So for the sequential Cox analysis, we took each of the 328 IRD recipients and we created a comparison group for them. The comparison group included all candidates on the waiting list who were active on the waiting list on the day of the IRD transplant. So we created 328 comparison groups for each of the 328 recipients. And each of those comparison groups and recipient combination was called an experiment. So we followed members within each experiment from the date of the IRD transplant to the earlier of the date of death or the end of SRTR follow-up. Patients who subsequently received living donor transplants were censored, and patients who subsequently received an increased risk donor transplant were also censored. So we were really comparing IRD with either remaining on the list or IRD with a subsequent non-IRD deceased donor transplant. So this is the distribution of IRD donors based on our results. Most of the IRD donors came from Texas and California, followed by Illinois, New York, and Florida. These results not surprising because these results correspond with the population density of these states. So, during the study duration, 6% of all deceased donor kidney transplants that were performed in the United States were from increased risk donors. Here you can appreciate in this figure, only if I can get this mouse to work, that the IRD utilization rates were not constant throughout the study period. We see a steep rise in the rates here in 2013. This is when CDC updated its guidelines. So it's quite possible that the increase in rates that we see here is more a reflection of the newer guidelines, which were more stringent and more inclusive. Nevertheless, in 2015, about 13% of all deceased donor transplants were IRD transplants. But as I previously mentioned, 20% of all deceased donors are IRD donors. So there is a gap between the availability of IRD donors and utilization of IRD donors for pediatric transplants. This table compares donor characteristics between IRD and non-IRD donors. And we can see that IRD donors are more likely to be male, more likely to be Black, and less likely to die from stroke. We found no difference in the kidney quality. So we compared a score called KDPI. KDPI stands for Kidney Donor Profile Index. It's a score that's assigned to each kidney, which tells us about the quality of that kidney. It predicts the risk of kidney failure subsequently. So the lower the score, better the outcome, better the quality. And the mean KDPI score, and the score ranges from 0 to 100, and the mean KDPI score for both was about 19. Now, in adult recipients, the IRD donors have a significantly lower KDPI score. But in pediatrics, we did not find this difference. And again, it's not surprising because children are given priority for better quality kidneys. And according to the new kidney allocation systems, you can only get a kidney with a KDPI of less than 35 if you're a child. Hence, we did not find that difference. This table compares recipient characteristics between IRD recipients and non-IRD recipients. We found no difference in age of transplant, gender, race distribution, pre-transplant dialysis, or pre-transplant dialysis duration. However, we did find that IRD recipients were more likely to have blood group O. Now, blood group O is the most prevalent blood group on the deceased donor list. And blood group O is also the blood group that's associated with the longest waitlisting time. And this has to do with the fact that many blood group O kidneys are routed to other blood types, and hence the blood group O tend to accumulate. We also noticed that IRD recipients had higher mean CPRA. PRA stands for panel reactive antibody, and it tells us about the degree of sensitization of the kidney to, or degree of sensitization of the recipient to a pool of local donors. So higher the degree of sensitization, longer is the expected wait time. So, in brief, IRD donors were found to have characteristics, or IRD recipients were found to have characteristics that are more consistent with long waitlist time. And that again makes sense, because that's probably what prompted the providers to go with an IRD kidney. So, in terms of outcomes, we found no difference in delayed graft function between IRD and non-IRD recipients. We also found no difference in 1-year acute rejection-free survival between IRD and non-IRD recipients. This Kaplan-Meier curve compares patient survival, 5-year overall graft survival between IRD and non-IRD recipients. And you can see that the curves are pretty much superimposed. So there's hardly any difference in the overall 5-year graft survival between the two groups. This slide gives 5-year death-censored graft survival. And again, we found no difference between IRD and non-IRD recipients in terms of the death-censored graft survival. And here we compare patient survival between IRD and non-IRD recipients, and again, there is no difference. We used Cox proportional hazard model and adjusted a model for age of transplant, sex, race, pre-transplant dialysis, and CPRA. And using the Cox model after multivariate analysis, we again found no difference in either the graft survival or the patient survival. So our first hypothesis, we were unable to reject the null hypothesis, so there was indeed no difference between the two recipients. And again, probably had to do with the fact that there was no difference in the KDPI. This is the most important slide of this presentation, and this is the most important finding of our study. So we found that IRD transplant is indeed associated with a survival benefit compared with remaining on the waiting list for a non-IRD kidney. And this is for pediatric patients. Now, a lot of people argue that pediatric patients don't have to wait very long, so why take that additional risk? But we've seen that pediatric patients may have to wait long. And this data also shows there's indeed a survival benefit of an IRD transplant. So our adjusted hazard ratio was 0.48 with a p-value of 0.018. So it's not just borderline significant, it's quite significant. So IRD recipients have a 52% lower risk of mortality compared to remaining on the waiting list for a non-IRD kidney. We adjusted our model for age of transplant, sex, race, pre-transplant dialysis, panel reactive antibody, ABO status, because again, there was a difference between the two recipients for that, as well as transplant center. Because maybe some of the transplants who are performing IRD transplants are more experienced and are associated with different outcomes. Unfortunately, we could not assess virus transmission rates in our study because SRTR just does not contain that data. But we tried to assess virus transmission indirectly, somewhat. SRTR does have data on hepatitis B treatment, so we saw if there was any difference in hepatitis B treatment received by IRD versus non-IRD recipients. None of the IRD recipients received treatment for hepatitis B. 15 of the non-IRD recipients received treatment for hepatitis B, and again, the difference was not significant. We were unable to assess the virus transmission data because SRTR doesn't have it, but UNOS has that data. So we reached out to UNOS and we asked them if there have been any cases of HIV, hepatitis B, or hepatitis C transmission via transplantation in pediatric kidney recipients. And we found 0 documented cases of HIV, Hep B, Hep C transmission. Again, you have to think of the survival benefit and you have to think of the risk that these increased risk donors pose before you decide whether to accept or decline an IRD offer. We also looked at causes of graft loss and death and saw if there was a difference in graft loss and death due to infection. And again, we found no difference in graft loss due to infection between IRD and non-IRD recipients, and we found no difference in graft loss or in death due to infection between the two groups. So what are some of the key findings of our study? Again, in 2015, 13% of deceased donor transplants in children were IRD transplants, whereas 20% of all deceased donors are IRD donors. So this indicates underutilization of this resource for children. Adult data also indicates that IRD kidneys are likely to be underutilized. A retrospective study of 45,000 deceased donor transplants showed that IRD kidneys are 8.2% less likely to be used compared with non-IRD kidneys. Another study of 35,000 deceased donor transplants showed that IRD labeling of a kidney results in 313 fewer kidney transplants per year. So what are some of the reasons for IRD underutilization? Fear of transmitting a stigmatized infection is a big reason. In 2007, an IRD donor transmitted HIV and hepatitis C to 4 adult recipients, 2 kidney recipients, 1 heart recipient, 1 liver recipient. That has been the only case documented so far. That patient had tested negative on ELISA for both those viruses, but NAT had not been performed. So retrospectively, they performed NAT on the donor, and indeed, the donor tested positive for both viruses. So that case led to a lot of uproar in the transplant community, and there was a lot of reaction to it. A survey was done of transplant surgeons after that case and showed that most of the transplant surgeons changed their practice after the incidents, and most of them decreased the utilization of IRD kidney after that incident. So again, fear of transmitting the stigmatized infection, fear of legal repercussions, and fear of negative publicity are great deterrent. Hospital pressures have also been cited as a cause for not using these kidneys because hospitals do not want negative publicity. And then lack of awareness about IRD kidneys, misconceptions about IRD kidneys, lack of knowledge about the benefit and the magnitude of risk also play a role. A survey was done on nephrologists and showed that 35%, or 1/3, were unfamiliar with increased risk donors. Now, these are nephrologists who deal with transplants, and 1/3 of them were also unfamiliar with increased risk donors. And what's more, 40% felt ill-prepared to counsel their patients regarding IRD use. So your patients will not be able to make an informed consent when you yourself are not educated about the risk and the benefit. So what we need to do, we need to educate ourselves about the magnitude of the risk. We need to understand the benefit that comes with IRD transplants. And then we need to equip our patients with this knowledge and then let the patient decide. We don't have to decide for them. We don't have to tell them, take this risk. Let them decide. But they have to know what they're weighing. They have to know what's the benefit and what's the risk, and is it justified to take the risk. We also found that IRD recipients were more likely to have blood group O and high CPRA. Again, these are characteristics that portend long waitlisting time. Hopefully, we'll be seeing more of IRD transplants, and it'll not only be just these recipients. We found no difference in post-transplant Hep B treatment. We found no difference in graft loss or death due to infection. There's another study that came out that looked at virus transmission in pediatric solid organ recipients. This study was done using OPTN data on 11,000 pediatric solid organ transplants. and found 0 cases of HIV transmission, 0 cases of hepatitis C transmission, and only 1 case of hepatitis B transmission in a liver transplant recipient. Again, this slide talks about all solid organ transplants. The data that I shared previously about Eunice was only for pediatric transplants. Now, 2 things. 1, there was only 1 case of transmission. 2, we also have to keep in mind that there is vaccination available against hepatitis B. So the risk of transmission has to be taken into account in light of that information. Number 2, hepatitis C is no longer an incurable illness. So yes, the risk is not 0, but you're looking at a potentially treatable infection. And there have been reports of kidney transplant or organ transplant recipients with hepatitis C who have been cured after the fact. Sorry, how old? So again, in adults, you know the case that I mentioned in 2007 when one IRD recipient transmitted infection to 4, or one IRD donor transmitted infection to 4 recipients. That's the adult data. And I'll come to some adult data right here. So there were 2 studies done on adult recipients. So one study looked at 51 IRD recipients. Here we're not looking at all organ recipients, we're looking at only IRD kidney transplant recipients. And this study found 0 transmission of either of the viruses over a median of 11 months. Another study was done using NAT testing among 257 IRD recipients. And again, no case of virus transmission was found, even in adults. So moving on to our findings, we found no difference in patient and graft survival between IRD and non-IRD recipients. So IRD recipients do just as well. And we did find that IRD recipients had a superior patient survival compared with remaining on the waiting list and waiting for a non-IRD kidney. The survival benefit has also been demonstrated in adult studies. A retrospective study was done on about 100,000 IRD kidneys that were declined by adult candidates. Now, these kidneys were subsequently accepted by different candidates. So the authors compared those candidates who had declined those kidneys and those recipients who had received those kidneys. They found that the candidates who had declined the IRD kidneys, only 31% of them subsequently received an offer over a period of 5 years. And patients who had accepted those IRD kidneys had 48% lower risk of death 6 months post-transplant compared to those who had declined those kidneys. So again, the survival benefit is all over the place. It's there for adults, it's there for children. So what were some of the limitations of our study? 1, this is a population-based study, which is also its strength, but because it is using national data, the data lacked granularity. We did not have data on virus transmission, and hence that's something that we could not report. Number 2, we only report 5-year follow-up data. Now, it has been shown that patient survival difference between hepatitis C infected transplant recipients and hepatitis C uninfected transplant recipients may not manifest until about 10 years after the transplant. It has also been shown that a 5-year graft survival difference may not be appreciated between HIV infected and HIV uninfected kidney transplant recipients. The third limitation of our study was misclassification of the IRD status. As you may remember, CDC updated the guideline in 2013. So it's possible that a lot of patients who were considered standard criteria donor before 2013 would have been increased risk donors per the updated guidelines. So there was some misclassification. But if you think about it, this misclassification should only make our estimate or our effect size smaller and should only take it closer to the null. So in other words, it really shouldn't compromise the validity of our study. So the recommendations based on our findings. Based on our study and taking into account the degree of risk associated with IRD donors, we recommend that IRD transplants should be considered in pediatric kidney transplant recipients. The risk of virus transmission is negligible, but the risk is not 0. So informed consent must be obtained And again, you do not decide whether to accept or decline the kidney. It's the patient who decides that, but you have to share the risk and the benefit with them. And number 3, increased utilization of IRD kidneys would just benefit the transplant community as a whole by decreasing somewhat the organ shortage. Thank you. Any questions? Sure. Infection risk. No. Increased risk donor only has to do with the risk of transmitting HIV, Hep B, Hep C.
So congratulations. I mean, this is really a great study.
Thank you.
Really important data. So I think that's terrific. I wanted to ask about hepatitis C a little bit more. You showed some lamivudine data for Hep B. That was interesting. And I guess over this window of time, what we've seen is hepatitis C now evolved to a curable infection
Correct.
for many people. And in the database, was there any information at all about the newer drugs for Hep C infection in children in particular? Because they aren't widely used
They're
yet
available.
in kids, but something to think about.
Right. Well, thank you so much for this question. That's not something that we specifically looked at because, I don't know, SRTR may lag behind a little bit, but that is definitely something worth looking at in the future. And I'll just add that to my list of research projects to do. Thank you. So there are a lot of Correct. So a lot of transplant surgeons and nephrologists are actually promoting using hepatitis C positive donors based on the fact that hepatitis C is not curable. There was one study that I read, according to which 500 kidneys are discarded annually because of hepatitis C positivity. And again, that's a big number.
What do you find the response of parents is when you go through this informed consent process? Are most willing to move forward with an IRD kidney?
Yeah, it's very interesting. Since the paper came out, we performed 2 increased risk donor transplants. It seems like, I don't know, maybe they're coming up more, or maybe we're offering more. We've been boldened somehow. I don't know, but we've done 2 transplants over the last couple of months. And they both happen to be my patients, even though I'm not the one who had the discussion with them. And when I talked to the mother of one of the patients, making sure that she understood the risk, and she said, yeah, we get the risk. The risk is small. So I think the benefit of kidney transplant and the stress associated with dialysis, patients will do anything to get rid of dialysis. They want a normal life with a normal quality of life.
Hi, Sarah. Do we talk about this with the patients, like when they're doing the workup, or is it only if it becomes available that we talk to them about it?
Right now, we're only talking about it when it becomes available. That's what's mandated, that you have to take informed consent when you offer that kidney to them.
So they don't know that this could be an option before it becomes available?
We don't specifically talk about it, but that's something that we can discuss as a group.
Okay, just curious. And
Yeah,
also,
I think it's a good point. If we mention it beforehand, then they'll give them more time to think about it, and
Right.
they're less likely to say no on the spot
Right.
if they've had time to dissect the risk versus benefits. So I think it's a good point.
Right. And then I was also wondering, do we only take IRD of like deceased donors, or are they living as well?
That's a very good question. Right now, it's only the deceased donor.
Okay.
But yes, it's a good question. Because if you have a living donor who abused drugs a week prior to donation, that also raises serious questions about the donor himself and how serious the donor is. But it's the deceased donor at this time.
When I do my teaching for the transplant patients, we do mention that they might be offered a high-risk donor and that the surgeon or the doctor giving them the offer would go into more detail at that time.
Great.
think along with what other people were saying, I'm wondering about the development of standardized information sheets or things for patients, since probably different nephrologists are presenting the information each time. And if there's a somewhat of a learning gap, just some sort of standardized information for parents in language that would be appropriate just as a teaching tool, either before the decision has to be made or before.
Yeah, I think that's a very good idea, something that we can discuss in our transplant conference. Thank you. Thank you. Thank you. Thank you. Thank you. Well, I take that as a huge compliment. Thank you. It's not zero. Oh, thank you. Thank you. Thank you. Thanks. Thank you.
You have been disconnected from the meeting.